Hello, everyone, and welcome to the Royal College of Surgeons of Edinburgh RSA series of webinars for the undergrads. Today, we'll be discussing the physiology of wound healing. We've got the pleasure of having Mr. Saleh, Dan Saleh from the northeast of England. He's a consultant plastic surgeon with interest in microvascular surgery and oncology. He'll be telling us about the physiology of wound healing, will telling us about patient factors and methods of achieving wound cover. All to you, Dan.
Thanks, Eamon. Can you hear me okay? Yeah. Welcome, everybody. I hope this is a very quick crash course in sort of wound healing and a basic introduction to how we can try achieve that and the things that you should try do when faced with tricky wounds and what we do as surgeons, which is most of our operating days, we're wounding patients. And we need to look at them as the whole thing, not just an isolated scar. Let's get this to work. So there's a few broad principles, but basically the skin's the biggest organ in the body, and it's involved in doing a number of things, varying from homeostatic regulation to hormone regulation, endocrine functions, and fairly complex pathways in not only protecting us and our insides, but also ensuring that we grow and ensuring that we keep a normal temperature to allow everything else to work in a nice oiled fashion. We'll talk a little bit about how and what wounds are and the different types of wounds and how they behave slightly differently when they try to heal. And then some basic points about tissue repair and what we do as surgeons and what generally we would hope to see as surgeons, and then ways of achieving more complex wound management and cover and things that we can do to help patients achieve healing when we're struggling to get that done. So a wound really is any defect in the continuity of the skin. And the skin is essentially a bilaminar structure. So we have a very thin top layer, which is the epidermis. And depending on what you read and how complicated you want to make it, is a couple of cells thick. And the dermis is where the real strength in the skin lies, which is a significant component of collagen. And the dermis varies in depth in different parts of the body, which is probably an evolutionary trait. And the dermis houses a number of appendageal important structures that are involved in the things that I mentioned earlier. And the reason that skin has a slightly different capacity to heal compared to other tissues is keratinocytes and skin cells are generally labile cells, so they have significant regenerative potential, and they have significant potential to influence each other when side by side to get an area of breach in the skin to heal and to restore continuity, because restoring continuity will retain that barrier to our outside environment. So what actually happens when we're wounded? Well, if we just take a very simple abrasion or a cut, the surface of the skin will, in normal physiological conditions, go into a form of damage limitation. So it will try and restrict either that wounding going deeper or more lateral, and it will also restrict the local injury to the structures. So small blood vessels will go into vasospasm to try and limit the blood loss and to start building the blocks to heal. And then in the repair phase, we'll get a number of different cells and competing cells that signal to each other to essentially join the fight, to bridge that gap and to start repairing it. And then that provides a matrix and a scaffold for things to regrow. So in essence, there's probably 4 or 3.5, if you like, broad phases of healing. So in its crudest sense, the initial wounding, however big or small, there'll be bleeding. And ideally, in an ideal sense, a clot will form in that wound. So the bleeding will arrest, the initial bleeding will hopefully stop, but the bleeding that has occurred is rich in platelets, white cells, red cells, a number of cytokines and signaling pathways, and that will form a secure clot, which will then gradually change its morphology as you get new inflammatory cells infiltrate the area to remove the debris, remove the mess. And then that will, once the mess is removed and the conditions are appropriate, we'll get nice proliferation of new cells, which will start building from the ground up, in essence. And then we get continuity of the epidermis over that when we remodel. And the remodeling phase of scars or a fresh wound that has healed into a fresh scar can take many years. There are some subtle differences between what is repair, what's regeneration, and it wasn't up until really recently that we really understood how small a wound could be where you literally could not see a scar. Embryologically, we've never really fully understood the science to why scarring in a fetus does not translate as a visible scar or a change in the cutaneous architecture of that same baby when they're born. And we haven't understood the pathways of why fetal scarring is scarless, or sorry, fetal healing rather is scarless. But what we do know in the normal human circumstance is that we will always have significant turnover of cells and dead cells in our skin surface. So we're constantly shedding skins, and inflammatory cells, macrophages predominantly, will gobble up the mess and deal with it and remove it. And that doesn't normally leave a footprint of scarring. It can in pathological immunological conditions, but in normal circumstance, you would leave behind a normal epidermis and a normal dermis. When the cellular loss is of a particular magnitude and threshold, and we think that's about a 22 gauge needle, for example, you will see a actual replacement of proliferation of new inflammatory cells. And so that gives you a scar that is potentially visible because it's restoring continuity, but in a slightly different way to how it was made in the first place. And regardless of the type of wound, whatever granulation may be within a wound, so that's the inflammatory load of cells and debris being cleaned at the same time, that is replaced with these regenerative and reconstructive sort of pathways within the skin that produce a scar. So when in the surgical realm, when we're dealt with patients that we know we're going to injure and traumatize in a controlled fashion, we have to consider, well, what is an acceptable time frame for this patient to heal? Can we get this patient to heal from what I propose to do to them in a manner that isn't intensive to their time, potentially my time and my colleagues' time? Patients don't like coming into hospital. They don't like coming for wound dressings. They don't like having dressings for prolonged periods. They just want to get on with life. Will that wound and that final scar be in a position where it will be functionally sound and appropriate? Will it be cosmetically sound and appropriate? And I'm not just talking about the face or the head and neck. Patients are can be psychosocially hindered by scars in places that you would not think were important. And will that scar be pain-free or symptom-free with ideally normal sensibility in the skin? And will they go on to get a mature scar that won't give them redness, lumpiness, widening, or abnormal types of scar? And abnormal types of scar, anybody can produce an abnormal types of scar. Far East Asian genetics and Central African genetics and Celtic genetics have a propensity towards abnormal scarring where full maturation is never reached. There's a continual turnover of the attempt of the skin and the scar to try and mature, but it can't. It just keeps in this cycle of prolonged scarring. And that can sometimes be difficult to manage. And that's a whole spectrum of things from hypertrophic scarring, which just means red and lumpy and raised, to keloid scarring, which is really a type of scar that almost transforms into a slow-growing benign tumor of the skin. So broadly, I suspect that you'll all be familiar with what we call primary intention, which is where we create a wound and we primarily repair it with the intention of it healing as quick as possible with the smallest footprint of injury. And then we've got secondary closure, which is what most people have in their head as a wider area of scarring where the wound either can't be opposed or the wound has been deliberately left open to heal in a different manner. Secondary intention of healing is generally more prolonged, because it's relying on a different group of cells to achieve that wound healing. So in primary intention, we have those normal phases that I said. You get a bleed, you get an acute inflammatory exudatum process, which then allows new cells to proliferate and build and to go on to a remodeled mature scar. Whereas in secondary intention wounds, you get a layer of granulation, which is a mixture of these inflammatory cells and dead material, which aggregates on the surface of the wound. You may know that affectionately as slough. And what happens is underneath that, we have new cells and the building blocks of new tissue being laid down, with also a significant influx of contractile cells. So rather than just fibroblasts, you get myofibroblasts, which then try and encourage wound contraction to bring the wound edges together. And that's a much longer process and tends to leave a bigger footprint of scarring because of that primary contracture. So how and what does that give us in terms of wound strength? Well, actually, it takes the first week after surgery, where many wounds may have sutures removed or at least a dressing change, you only have about 10% strength of what the original dermis tensile strength is. And remember, I said the strength is in the dermis. So quite often, unless it's a very, very lax wound and it's on somewhere like the face or the back of a hand, it is always useful to try oppose the dermis, because that's where you'll get your strength of healing from. And it can take, beyond really 3 months before you even get close to having 50% tensile strength within the wound. So some patients will need wound support for 2-3 weeks before you can take sutures out to allow that sticky proliferative phase to really let the wound heal in an appropriate manner. And it takes up to 2 years to get the plateau of the maximal strength you'll get in an incisional wound, which is about 80%. And at that juncture, we would hope that the maturation phase is completed. So outside of our fetal lives, we can only ever achieve an 80% strength of a wound, and it takes a long time to get there. And that's why we see in surgery, even with the best of intentions, with the best patients and the most physiologically strong and capable patients, that we see wounds fall apart at a week, 2 weeks, 3 weeks, and that's a major part of our work. So it's probably a reasonable time now to introduce the reconstructive ladder. And this is a relatively old concept, and this will change later in the talk. But in patients that we don't feel comfortable just leaving a wound to heal, where there's very good examples of good times to do that, and we can't stitch the wound together to close the wound to expedite healing for patients to get a healed wound quicker and to get on with their lives, then we're in the realms of trying to facilitate wound healing by different measures. I think it's important that something that always gets missed off this diagram, whichever book you look in, is secondary intention healing also goes hand in hand with wound therapy and dressings therapy, of which there's a whole multitude of different types of dressings to increase wounds to become wetter, for the slough and the debris to lift off easier, for wounds like negative pressure dressings or vacuum dressings, which aim to reduce the edema in the wound and expedite the primary contracture to get the wound to heal. But beyond that, there are a number of things that we can do to try and get a wound to heal. And that can range from taking a shave of skin of either a split thickness or the full thickness of the skin to cover a wound that won't directly close, to using some of the local tissue adjacent to the wound, which is a local flap or a regional flap. Flap meaning just a unit of tissue that you transfer from one place that you can reasonably borrow it from to cover a wound that you've encountered which needs tissue. And then free flaps or free tissue transplants, where we transplant a piece of tissue from somewhere else in the body to cover a part of the body that has a more pressing need. And normally when we do free tissue transplants, we weigh up what the patient wants, where's a good place to take tissue with minimal functional impact on the patient, and ideally taking it from somewhere where we're not creating another wound and another problem that might delay their onward surgical journey, whatever that is, whether it be an accident they've been in where they've injured their leg and we need to cover the bones to heal, or whether it be a breast reconstruction following breast cancer or some other form of soft tissue tumor.
Hi, Daniel. Are you struggling to get the next slide up?
I just lost my... There, we're back on business there?
Yeah, there we go. So if you click now, you should be able to... There we go.
Yeah, sorry about that. So, secondary intent healing. Provided the conditions are correct and the physiology of the patient is optimized, anything will heal. You just need to leave it long enough. And if the patient will tolerate leaving it long enough, you can get anything to heal. So this patient had a significant burn across the thigh. You can see some areas have been stitched together and a little bit of skin graft, but they had probably about a 10 centimeter by 15 centimeter wound. They were sick to death of having operations and skin grafts. So we made sure that that patient was optimized and we could then achieve healing over the course of about 3 months. So why do some wounds fail to heal? The list is far longer than this. So the general principles I would advise are: consider whether the patient had the wrong type of wound closure. This is in planned surgery, if we keep it to that. Have they had blame the patient last, basically. Blame yourself first and those around you in the team first, and blame the patient last. Even if you'd like to blame the patient first, it's just the world we live in. There's also things that really come under our jurisdiction but are the patient's fault, and that's things like their physiological status, their smoking status. Are they putting pressure on their wounds? Are they on medicines that inhibit healing? Do they have diseases that inhibit healing, ranging from all of the autoimmune kind of conditions to connective tissue diseases to diseases we don't really fully understand, like ongoing cancer, for example? And are they in a catabolic state? So does this patient need nutritional support, or is their nutritional support very poor at home? And is there something that we need to do to optimize that to allow this wound to heal? If patients generally have the building blocks, particularly protein intake, they're likely to be equipped to synthesize the things they need in their liver and elsewhere to get a wound to heal. And certainly for patients that have large wounds, there's very good evidence now that if they're getting about 80 grams of protein a day, they're more likely to heal than if they're getting as little as 40 grams per day. So that's very well documented and very clear. And those of you that look after patients on the gastrointestinal wards and the upper and lower GI surgery wards will be well versed in that. Poor wound care is very common, unfortunately. And I'll come full circle back to that. And some patients just won't comply with what you tell them. So if you tell them, don't do this, don't weight bear on that, don't lift your arm here, keep your arm elevated, wear a sling, and they don't do all those things, then it's reasonable to start blaming them as well, in the comfort that your technique has been exemplary. This is really, I've sort of pretty much said this. The systemic things sometimes we can't always modify. So we can encourage them to eat, but if they can't, or they're not on enteral nutrition, then that's a challenge. Things like anemia are becoming very prominent, particularly in an enhanced recovery of our surgical patients. And correcting anemia pre-surgery is a massive, massive bonus, where possible, to achieving wound healing. And sometimes there are complications of giving patients blood, for example, if they can't have short courses of iron therapy, if they've got iron deficiency. But ultimately, correcting anemia is a very powerful tool in improving their chances of getting wound healing. The things that you can directly intervene, though, aside from that, are really, if you're faced with a wound that belongs to somebody else, or you've got a wound that's broken down, is maximizing the blood supply to those wounds, or ensuring there's good blood supply to those potential wounds. A good example of that is my vascular colleagues, when they're planning surgery in patients who have vasculopaths, or they're planning operations on improving vascular ulceration, they'll try augment the blood supply to that limb to allow the healing or facilitate the healing, and they can do that endovascularly in a variety of ways. And can we improve the wound contamination, which comes back to poor wound care? And if they've got prosthetic material sitting in the bottom of that wound, well, the wound is never going to heal if there's something foreign there that doesn't have a blood supply. And as we enter, the last couple of years have seen a dramatic improvement in enhanced recovery programs. Many hospitals invest heavily in this. We don't have official enhanced recovery pathways for plastic surgery, but we have them emerging, and we've looked to our gastrointestinal colleagues that we work with who are quite well versed in this, but it's very self-explanatory. And basically, if you've got a healthier patient, you're more likely to achieve a better outcome with wounding or treating their wound. So how do we examine a wound? So aside from the physiological status of the patient and sorting out their potential modifiable factors, ultimately, if you're faced with a wound that looks like it's got dead tissue, you need to remove that tissue. So this is an example of a wound that has got redness around it. It's probably a little bit unhappy and got some low-grade infection in it. And you can see in the lower, this is the mid portion of somebody's shin, you can see the lower part of the wound, there is a little black patch. That's probably dead skin that hasn't quite made it through. And you could argue you could dress this and it'll be okay in 2 or 3 months' time, but as long as you've got non-viable tissue there that may be contaminated with a bit of infection, i.e. the redness around it, then that probably needs removing, like debridement. And debridement can remove eschar. So eschar is just black areas of dead, full thickness skin, the dead fat underneath it, which is quite common, slough, which is the surface granulation, which can contaminate wounds and be a barrier for reepithelialization at the ends of wounds, and any foreign material. And probably when you're examining a wound, examining the patient's status in the limb, can they move the limb? Have they got maybe a more deep-seated infection that might be causing a problem above it, with the skin above it, is also an important consideration. And whether you need to swab the wound to get what their microbiological status is. And always take a photo. And certainly in COVID times, we're allowed to use WhatsApp now. So whether unofficially or officially you were doing that before, you're getting a chronological view on wounds is very helpful. So when you debride these wounds back to the healthy tissue, then you can start thinking about what the best mode for that patient is to get that wound to heal. This is just a slide to show you what slough looks like. So slough can impede reepithelialization of wounds, but also it's the natural exudate and the amalgamation of the debris that you see in skin. All slough is contaminated with some surface staph and streptococcus and even Pseudomonas, and you have to make judicious decisions to try tailor your wound therapy to allowing that slough to lift off. So when you're dealing with wounds like that, which are chronic, and you're trying to get the patient in a position where they can either have delayed wound closure or reconstructive surgery, or just to let it heal on its own, you've got to keep it clean, regardless if that means you've got to dress it every day and change your dressing every day. It's got to be a moist environment, otherwise reepithelialization won't occur and the proliferative phase can't occur, and it's got to be free from contaminants. So that brings us full circle back to how to help wounds heal if we need to do that surgically. And that's where the reconstructive elevator, I think, comes into play. So we want to look at bespoke solutions for bespoke surgical and patient problems. So if a wound can't directly close, then you're faced with a situation of, will the patient accept me leaving this to heal on its own? It might take a while, but they might be entirely happy with that. Or do I need to deploy some form of reconstructive procedure? And that doesn't need to go sequentially up the rungs of the ladder for, oh, I've got an open wound and I can't close it, therefore I must use a skin graft first. And if that fails, then I must use a local flap, and so on. You can dive straight into something more complex if it's the right thing for the patient and the patient can tolerate that kind of procedure. So, split skin grafting. When you have a clean wound free of contaminants, like the top left, there's some areas of muscular tendinous junction exposed here and there, but otherwise that's nice, healthy wound bed. There's no surface slough, and we can see reepithelialization happening at the edges. But the patient doesn't want to wait another 6 months for that to heal on its own. So you can put a skin graft on it. And overall, it takes a couple of years to mature, but they get a functional result, albeit it might not be the most cosmetically pleasing. Skin grafts heal in a slightly different way, and those of you that speak Greek or are Greek might be familiar with some of these terms, but imbibition is basically when a skin graft sticks to a wound bed. So when you put a skin graft on, it stimulates that inflammatory phase again. You get a lot of fibrin deposition, and the fibrin sticks the skin onto the wound. And then over the next 72 hours to 5 days, you'll get what's called inosculation, where there's small blood vessels that are residual in that dermal interface of the skin graft and the wound bed, and the little small blood vessels and capillaries in the wound bed will join through angiogenesis, and then that'll deliver some blood supply to the skin graft, and then it can undergo full neovascularization within a week. And within a week, you should have a fairly stable skin graft stock on the wound bed, and that'll go on to mature in a couple of years' time, but they'll get certainly wound continuity within 10 days to 2 weeks. If we're going to try be a bit more adventurous and use a flap of tissue in the near locality, you can do this through what we call random pattern flaps. So we just know, which I won't get into the minutiae of, that it will just work if I cut a piece of tissue here and move it over there. But ultimately, everything works on having a blood supply. You'll be familiar with dermatomes, and there's something called angiosomes as well. So there's blood vessels and axial blood vessels that supply the blood supply to specific portions of skin everywhere in our body. And these axial blood vessels, like the main blood vessels in our arms and legs, for example, they give off perforating vessels which leave the main trunk of the vessel and zoom all the way to the surface of the skin. So these X's on this leg mark where we can hear those vessels with a Doppler. We've got a tumor that we've got a circle around that we're going to take a big margin around, and that's going to leave a fairly big hole in this patient's calf. So we can lift that island of skin on those blood vessels, and we can transfer that skin to cover the defect of interest. So the bottom left diagram there shows that we got 2 blood vessels that are coming from the anterior tibial artery into that skin, and we free that skin from all of its fascial attachments, and then we can slide it to where we want it to. And that's a local flap or a local regional flap, and that's a very straightforward technique and works very well. And then in patients that have slightly more challenging problems, and our chair, Eamon, for today will be familiar with this. He's a limb reconstructive surgeon. Sometimes we have to get a bit more creative, and we don't have the opportunity to use local and regional flaps because the wound is too big, or it's not in the right configuration, or it's not nearby enough to a good blood vessel. So we take a piece of tissue that we know has a reliable blood supply and take it with its parent artery and vein, and then transplant it to somewhere where we need it. And that does require a donor site, so we have to try and ensure that the donor site has minimal impact on the patient, doesn't delay their healing elsewhere, and that they have good blood vessels in the vicinity of the injury to attach the artery and the vein, with there being minimal risk of complication. And that's another way to achieve what is in essence a primary intention healing wound, because we're transferring dermis to dermis and putting in stitches as we would as if we were directly closing it. And I think that's all I've probably got to say, and I hope that's generated some questions. And I'll stop there for the time being.
Thanks, Dan. That talk was excellent. You've covered many topics and you've been very thorough, and it's actually generated quite a lot of questions and interest from the audience, which is quite good. And I've selected a few questions for you to answer and discuss maybe live, because they're quite topical, and I think a group answer would help there.
Yeah.
So some of the questions, there's 2 questions about keloid. So so patients who are prone to keloid, what can you do as a surgeon to prevent it or minimize the risk of it? And if it happens, and once it happened, what can you do then?
Yeah, the keloid is a really big area of interest and disinterest. So a lot of people in surgery sort of run away from keloids as well. There's a definite genetic predisposition, and there's 2 groups of keloid patients in my opinion. I spent a lot of time as a trainee in South Africa where we had clinics full of patients with keloids. There's a group that develop keloids, which is an abnormal scar outside the boundaries of the intended incision that tends to grow very, very slowly over time and be quite symptomatic. So itchy, red, painful sometimes, may even leak material. And they're the types of keloids that arise in people that have genetic predisposition or don't have genetic predisposition, where the wound has been irritated by something. So they may have, for example, Ear piercing is a good example. People that aren't predisposed to keloids on paper, i.e. don't have an obvious genetic predisposition, if they get an infection, they get a keloid scar. So there's certain places like the presternal area, the anterior neck, the shoulders, the earlobes, behind the ear and on the front of the ear, where any interruption in that normal healing phase, whether it be a reaction to the suture material used in planned surgery or an infection from an insect bite or something triggers the keloid formation. And those patients actually do respond to surgery to remove the keloid much better than obviously patients that have a genuine genetic predisposition, which I'll come to in a minute. So there are a group of patients where I will operate on them, and we generally can do extra lesional excision in those patients, which you'll read in most books is a complete no-no, but I'll take it out like it's a tumor with a very narrow margin, and then suture the wound back together, give them prophylactic antibiotics, and start early compression of the wound, and generally they heal without too much bother. The other group of patients are much more problematic, that have a genuine genetic predisposition to keloids, and those patients, there's probably two avenues to go down. First of all, steroid injection into problematic scars, whatever the reason, are good at symptom control. So they're good at stopping the itching. They're good at potentially reducing the redness in people that have a Caucasian type skin or Celtic type skin, where the scar is red and lumpy, but it doesn't tend to get rid of the actual prominence of the scar. It might just change the color and the itching. And it doesn't tend to do anything other than hypopigment, darker skin type colors, and that can sometimes be more of a nuisance for those patients. So intralesional excision with on-table steroid injection, then a steroid a week later, whilst the evidence for that is very, very poor, generally speaking, you do get at least some improvement in the quality of the scar. And then that patient has to go on and have topical silicone therapy on that scar for a couple of years, and they may get a better result. And silicone probably works by hydrating the scar, but we're not entirely sure of the science behind that either. Radiotherapy in 5 fractions over a week is useful for keloids and can flatten keloids, but again, that has the added risk of things like, if it's presternal, radiation-induced fibrosis to the lung, to the mediastinum, to the pericardium, and osteoradionecrosis of the bone. So whilst radiotherapy has good evidence, it has more collateral damage. So it really depends on weighing up how much bothersome the scar is. The only other good therapy for keloids is like a form of electrochemotherapy using bleomycin, and there's ongoing studies with that, and that does hypopigment the skin in darker skin types, but is very effective at reducing the keloid load.
Great, thanks for that. Another question is about the difference between a graft and a flap. You mentioned in your reconstruction ladder that there is different options for covering soft tissue. A graft came in and a flap as well. So just to briefly, what's the difference between the two?
A flap is just any piece of tissue that has a recognized blood supply. So you're moving that tissue with its blood supply. Whereas a graft is you are disconnecting a graft or that piece of skin from its blood supply. So you're either taking a shave of the skin, or you're cutting out a piece of the skin in the case of a full thickness graft and putting it on the wound to neovascularize and pick up a blood supply from that wound bed. So that's the basic distinction, yeah.
Thanks for that, Dan. Another question about whether peripheral vascular disease is a contraindication to carrying out flaps in the lower limb.
In the vast majority of circumstances, it is a contraindication to reconstructing the wound with a flap if they have true peripheral vascular disease, because the adjacent tissue is, if you were using that, by definition would have an impaired blood supply as well. And then importing a free tissue transfer, you have to attach that blood supply to a reasonable blood supply target in that affected limb, which, if they have significant peripheral vascular disease, will be a challenge. There are certain exceptions to that, but that's probably the take-home message. And grafting, similarly, You don't lose a huge amount by trying a skin graft, apart from the donor site of the skin graft if the patient is willing to do that and the wound is clear of contaminants. But there's probably, there's a good recognized skin graft failure in vascular patients. And so probably just sequential compression bandaging is as good as it can get for a lot of those patients.
Thank you. Connective tissue diseases. So patients who have connective tissue disease problems, do they have different healing to your usual standard patients who don't have these conditions?
Yeah, they do. They do, but sometimes it's subclinical. And by that I mean they may have a connective tissue disorder, but we may not see that translate as a wound healing problem. And paradoxically, certain patients that have connective tissue disease, which is well controlled without immunomodulators or immune suppressants, actually can heal very well because their scar has just the right amount of immune response to induce a nice healing wound, and they go on to have a mature wound much quicker because the cycle of inflammation and immune response is damped down, if that makes sense. But generally, patients that have any form of immune modulation, chronic hematological disorders like polycythemia, chronic leukemias, their immune cells aren't functioning normally. And so that generally delays the healing process, or i.e. prolongs it, or can make it slightly abnormal where you get abnormal scars, but they still go on to heal. And sometimes they just heal longer. But it wouldn't make me stop their regular medicines necessarily. It doesn't make me stop their immunotherapies. And sometimes with the anti-TNF drugs and the very strong generation of immune modulators, you might time your surgery at the trough of their, a lot of these patients are on monthly or 6-weekly injections, and you time your surgery at the least potent phase of their treatment between injections.
Fully agree with that. That's what we actually do also for elective surgery in orthopedics. We do something very similar, which is timing the surgery when the effect of the anti-TNF is at its lowest. So I agree with that entirely. Dan, thank you very much. That's been very thorough, and you've delivered an excellent lecture, and I'm sure our audience have enjoyed it. I would just like to draw the attention of everybody that next week the lecture is about blunt trauma to the abdomen, so how to manage blunt trauma to the abdomen, and that will be on the 14th of July. Thanks all for joining, and enjoy your evening.
Thanks all. Thanks, Emma.